What I want to do this morning for you is to give an overview of tibial and pedal loop interventions and provide you with some tips. And what I thought to do was to give you a very brief overview of some backgrounds. The tibial loop, which are all of the connections between the anterior tibial, posterior tibial, and the peroneal artery. And then I will go also into the description of the pedal loop, which is actually the deep pedal arch and the plantar arch. Going a little bit deeper into the pedal loop, there are actually two connections at the level of the forefoot. It's the deep pedal arch that connects the superficial branch of the medial plantar artery to the tarsal artery. As you can see in this image that I took from a paper from Marco Manzi, a good friend and a pioneer in the pedal loop technique. And here you can see the images from this radiographics paper, which is really very interesting to read. Then we have the second connection in the forefoot, the connection between the dorsalis pedis artery through the deep perforating artery in the first metatarsal space with the plantar arch and the lateral plantar artery, as you can see on the images here. This is the main anatomy that you need to know when you're doing pedal loop recanalizations: the dorsalis pedis, the plantar arch itself, and then the connection towards the lateral plantar artery. And of course, there's also the medial plantar artery and the common plantar artery that you need to be aware of. So why would you use all these tibial or pedal loops? I think a lot of people currently are doing retrograde sticks, but you may already have started with your procedure with an antegrade approach, and the antegrade approach is much more versatile. You can use much more material, larger bore sizes of your devices, and most of the time you already have that performed anyway, or it's needed. Then there may be some practical reasons, logistics. You may not have ultrasound in your lab for one reason or another in order to perform this distal puncture. You don't need additional prepping of the patient, and sometimes you have not discussed the distal approach with the patient when obtaining the informed consent. And one of the other reasons is that you don't need distal hemostasis if you use the loops. Then you may not have experience with distal puncture, which is hampering the approach. And I think very important, and especially IRs are typically very conscientious about this, the risk of radiation exposure to the hands of the operator. The moment that you start manipulating in the distal vasculature, and you more or less get automatically exposure to your hands. And by using the loop techniques, this is something that you can avoid. Some other tips that I want to give you before I start showing you some cases is always use the optimal projection. As you can see on this image, it's very difficult to notice how the connection actually is between the medial and the lateral plantar artery and the dorsalis pedis and the plantar arch. And in an AP projection, you can see this much more clearly. And of course, this projection is much better to navigate through the forefoot. Also, the projection should really be optimized in order to see the connection between the anterior and the posterior circulation. Like in this case, you can see a microcatheter getting in from the dorsalis pedis across the forefoot towards the lateral plantar artery with this very difficult bend that is difficult to navigate. But when you project this in a proper manner, your navigation with your wire, as you can see on the right-hand side, is much more easy. Then it's very important to perform distal angiography once you're very distal with your catheter, and this can be also a balloon catheter. that is used for a selective injection using a roadmap technique. You can see a non-selective injection on the left-hand side, and on the right-hand side, you can see much better now the connection between the dorsalis pedis across the deep pedal arch towards the plantar circulation. And of course, when you have an image like this, it's much easier to make the connection that was needed in this case in order to recanalize the posterior tibial artery that was not possible in an antegrade fashion.